my apologies. So thanks so much for joining us on this special research rounds. This is one of the OVATioN rounds, and that's a special arrangement between the University of Ottawa Heart Institute with the University of British Columbia Division of Cardiology. And our speaker today, Christina Luong, is one of the rising stars at UBC, and we're absolutely fortunate to have her today. And the purpose of the OVATioN rounds is really to promote the academic collaboration and also mutual opportunities of working together, especially for junior and intermediate faculty members of both divisions. And so just a word about Christina. Christina is a clinical assistant professor at Division of Cardiology at the University of British Columbia. And she's the head of the stress echo laboratory at the Vancouver General Hospital. Christina obtained her MD degree originally from University of Alberta and subsequently trained in internal medicine and clinical cardiology at UBC. And she completed an additional 2 years of subspecialty training in echo at Vancouver General Hospital and also at the Mayo Clinic in Rochester. And she specializes in stress echo and trained with some of the world leaders in this domain. And but Dr. Luong, in fact, have very illustrious history of research and is doing a really interesting area of research at the present time as well. She's a UBC Friedman Scholar with a Master of Health Sciences in Clinical Research at the UBC School of Population and Public Health. And she had a first authored paper in Circulation when she was still at University of Alberta, working with Bernard Thibault and many of certainly our friends at the University of Alberta at that time. Of course, Bernard now is at the University of Ottawa. And he has won the Max Walters Cardiology Training Award and was also UBC Life Science Venture Accelerator and Lean Launch Awardee. Her primary area of research is in cardiac imaging, ultrasound, but with an emphasis on the new areas of application of artificial intelligence and machine learning tools to automate the acquisition, also analysis. And she works in close collaboration with the UBC School of Robotics and the Department of Biomedical Engineering, including renowned Professor Abelo Maisumi in electro and computer engineering at UBC. So we really look forward today to Christina's talk entitled Application of Artificial Intelligence on Echo and Cardiac Ultrasound.
Yeah, right.
Christina.
Thank you so much for the introduction and for the opportunity to present today. I should be sharing my screen now. So yes, as Dr. Liu mentioned, this is part of the Vancouver-Ottawa exchange in terms of presentations. And so we'll be talking briefly about AI and its application to echo at the current time and sort of some of the work that we're doing at UBC. These are the disclosures that I have. I'm supported partially by, for my research endeavors by VCHRI, and I belong within a larger research group, and these are some of the collaborations and grants that are funded there. So I'll start with a primer on AI in the context of cardiac ultrasound and echo research. Artificial intelligence, I don't think is a new term for anybody anymore. It's basically producing machines or models that mimic cognitive functions or human intelligence in the context of performing tasks usually. Within artificial intelligence is a method or approach known as machine learning, which is actually when we train models without actually explicitly defining what features that it needs to attend to in order to learn the tasks. So for an example of, say, a machine learning model, you would want it to learn what a cat is. So instead of actually telling it that a cat has 2 ears, 4 legs, and 2 eyes, you would actually provide it with many, many examples of what a cat is. And so for instance, if you're looking at imaging, so many examples of images of cats, and then many examples of things that are not cats, so that over time it would actually learn what features were most relevant to produce an accurate result. And then within machine learning is deep learning, which uses artificial neural networks. And this is kind of the most relevant type of approach with regards to echo research because it's imaging based. Now, how do you actually go about training these models? Well, there's kind of three different ways to look at this. You can look at it from a supervised fashion. And so supervised learning basically requires labeled data. So all those examples of cats that I had provided for the previous example would have to be labeled by a human or to ensure that there was actually, say, a correct allocation for the machine learning model in order to learn from. So it would look at the answer and then go backwards and learn the features that were most relevant. Another approach is unsupervised learning. And in this case, there's no annotations provided. And what the model actually does is produce clusters. And so in this case, you're provided with a large pool of data. The model's provided with a large pool of data, and it actually tries to group it out based on certain phenotypic characteristics or different features. An example of research in this area would be with heart failure with preserved ejection fraction, which we know is a heterogeneous group of patients. And in this case, the medical therapy and approaches for treatment have not been particularly successful, but that might be because this group of patients has different subtypes that respond differently to therapy and have different prognosis overall. And so some groups have looked at what types of groups within HFpEF are produced, and that would be with an unsupervised approach. And then reinforcement learning, which is basically learning from mistakes. So in the context of AI research with Echo, what we are usually doing is a supervised approach with deep learning. And one of the important ways to do that is with convolutional neural networks. And so shown here is kind of a schematic of what a convolutional neural network might entail. So if you imagine this black rectangle is a image of interest, this is a picture that the model will have to derive data from in order to produce a prediction of some kind of classification that is of interest. In order to obtain the data from this picture, it has to form an array of detection pieces, shown here as kind of an example, flashlights. So imagine a flashlight shining on different areas of the picture, forming an array. So each of the circles is a flashlight beam. And in reality, with the model, each of these flashlight beams is considered a neuron, which would activate if there are certain features that are present within it. If you look at the entire array that covers the whole area of interest, this would be known as a filter. So the filter is made out of multiple different flashlights that look at different areas. Each filter will look at a specific pattern. So for example, this first filter is picking up horizontal lines. So if there's a horizontal line present here, it'll activate, here it will activate, et cetera, et cetera. In order to form what's called the convolutional layer, which is basically the detection layer of the model, you have multiple filters placed in series. So in the last example, filter 1 was picking up horizontal lines, filter 2 might be picking up vertical lines, et cetera, and they're all placed in series to pick up different features. The convolutional layer feeds into what's known as a ReLU and pooling layer, which are layers that help to distill the most relevant patterns and downsize the data so that it can be processed in a reasonable timeline and processing power. And then finally, these data will get fed back to what's called the fully connected layer, which is the final layer that will provide the classification. So in the cat and no cat example, this would be the layer that would decide the probability of whether or not an image was a cat. This is just what it might look like with regards to echo images, and this is one of our papers. This figure's from one of our papers here. And so that is kind of the backbone for models which are required to do echo AI research. And when we're kind of producing these models, you want to allocate a certain number of data for training, validation, and testing. When we're talking about models for AI research, we usually talk in the order of hundreds and thousands of images or samples. And so at the outset, you want to set aside probably about 20% of the data for testing. And so that would be data that is not seen by the model at all with regards to training and validation. About 60 to 80% of the data will be used to train it, and then some portion will be used to validate it, which is basically when you optimize the model prior to testing. So now that we've talked about the background, the next things I'll discuss are selected advances in AI and echo research, and kind of interweave it with what's being done at UBC. So when we think about AI research in general, I think most of us, or most clinicians, would think about measurement and detection as being the primary goal of these models. And I think that's what garners the most attention, is when there's a model that detects some form of disease, or if it does segmentation or measurement in a way that's considered accurate compared to what's done as the reference standard. However, I think it's important to note that in order to get to these stages, there is a requirement to have some kind of model that will pick up image quality or detect image quality in order to reject very poor samples that will interfere with your training and testing. And also view classification, which is essential in terms of getting to these later stages as well. And so this is what gets the most attention, but these first two steps were probably the biggest barrier for getting into AI echo research to start with. And so I'll spend a little bit of time talking about what's been done in this area. So image quality is kind of one of the reasons why echo research was difficult to get into, because there wasn't really a method to or standard for qualifying what constituted as a poor, medium, or good and excellent quality echo image. And so it made it difficult to get into this field. However, we did publish something kind of in the early days back in 2017, looking at how to assess echo video quality and training a model to provide qualitative scoring or semi-quantitative scoring of echo image quality. This paper was looking at 5 different views, so apical 2, apical 3, apical 4 chamber images, as well as parasternal short axis at the level of aortic valve and papillary muscle. We had started initially actually with a still image of the apical 4 chamber, and generally for scoring purposes had done percentage of blood tissue interface that was seen for expected structures within that view. That was the first kind of paper, was just the still image apical 4, and we moved on to these videos actually, or cines, which is what was used to train and test on this paper here. We had used about 2,500 videos with the breakdown seen here. And on the left bar is what was graded by a cardiologist in terms of what was considered the quality there. And on the right is what was produced by the model. And so this is basically to demonstrate that there was relatively good correlation between the two in terms of performance. So this was kind of some of the foundation that was required from our point of view to get to where we are now. Our group is particularly interested with regards to POCUS, as it's deemed to be the area of growth for cardiac ultrasound, and with the expanding availability. And so we did apply this machine learning model for quality to POCUS platforms. And in this paper, we demonstrated that the model that we used for image quality and view classification, in this case as well too, could be loaded onto regular Android devices and hooked onto any ultrasound machine with a screen grabber kind of function on the phone to provide this kind of data that's shown here on the left. So the view as well as the image quality, just you could provide a number, but just for simplicity here, kind of a bar to demonstrate quality. The purpose of this kind of model is that it potentially can provide feedback in real time to assist with scanners in terms of optimizing quality or recognizing when an image is insufficient quality for providing interpretation. So there have been other groups that have shown view quality type of assessments as well too, but I was just highlighting our work there. View classification is the next step in terms of the progression of echo and AI research. And this particular paper had a lot of attention because it was published in the New England Journal of Medicine, Digital Medicine Journal. And this is a group, I believe, out of California that looked at basically the ability for a model to classify various echo views, as shown here, with both moving images as well as still frames, and compared it with performance of a human trying to classify view with a single frame. And so they used all the frames, so not necessarily end-systolic or end-diastolic. And so when you look at how the model performed using video, it was very good. So nearly 100% for many of the views. And then with single images, it performed a little bit worse, but certainly better than the human who only had access to a single image. And so this is one of the papers that showed that a machine learning model certainly could classify views, even with single images. The data set is relatively small in this case, but it seemed to produce a robust result. We also have a view classification model, and because we have this interest in POCUS, we applied the model that we developed using 3,100 echo separate echo studies, which included 16,000 videos or cines, and had an accuracy of about overall 88% for all the views shown here. Obviously, the apical 4, the parasternal long axis, and some of the more common views perform better. But the reason that I highlight this particular study is that the models that we used were considered quote unquote lightweight, which basically distilled down models that could be loaded onto to POCUS related devices or phones, which is similar to the video that I had shown before. And so they're generally faster and less require less processing power, which allow for their use to be a little bit more generalized. So image quality and that kind of aspect of echo remains a challenge, I think, in many ways because of the variability in terms of scanning skill as well as patient characteristics. And so our group actually has looked at methods for how to convert image quality or improve image quality for the purposes of tasks like view classification and segmentation. So this, I think, is probably particularly important in the context of POCUS or emergency studies when image quality is suboptimal. And so we've done a number of different studies that use this upconversion or translation of images from poor quality images or POCUS kind of quality images up to what would be considered images that look like they come from a high-end full functionality platform. So this is technically the quote unquote the real image. And then these are the translated or converted images that are enhanced. And so on the left, you can see that that the image quality has suboptimal endocardial definition, which is improved with this upconversion. And so I will end up showing some studies that use this upconversion process to show that it improves performance of various tasks. So this is kind of a tool that I think may be useful in the context of POCUS imaging for improving even visual assessment of function or LV size and whatnot. So this upconversion process, as I alluded to, does improve view classification So shown on the left side is the original image, and you can upconvert it to get this slightly better looking apical two chamber image. And the same thing here with this parasternal short axis at the papillar muscle level image. And the ones with the white squares are actually the originals. So this one actually has a down converted image as well too. But there is a significant improvement in terms of the ability for view classification when you have this process in the background. So now that we've talked about image quality and view classification, I think that's kind of readily available and completed now for most groups that do echo AI research, as well as for industry. And so now that this kind of process is finished, we can get to the more interesting aspects, which are things like measurement and disease detection. So for measurement, there are certain features that are required in order to measure, and at this point, it's segmentation of chambers and whatnot in terms of interest. One of those key things that are required is the detection of end systolic and end diastolic frames. This is easily done with ECG and is routinely annotated in all labs for measurement of end systolic and end diastolic size. However, it is a process that is more difficult when there is no ECG available. And because our group, as I said, is interested kind of in the POCUS aspect of cardiac ultrasound, ECG is often not something that is obtained or readily available with many of the devices that are on the market. And so we were able to demonstrate that we could consistently identify end systolic and end diastolic frames within about 3 frames as compared to the ones that were annotated by report and human interpreters. But it was absolutely essential, obviously, for the estimation of LVEF, wall thickness, and stroke volume from the point of view of future directions. And certainly we have been able to show that our machine learning models can estimate LVEF. And so this is specifically from apical views. So we've developed a model that looks at both the apical 2 and apical 4 chamber view to provide LVEF estimations respectively, as well as a combined biplane Simpson's number. Shown here is the correlation between the artificial or the ML model predicted LVEF, shown here on the y-axis, and on the x-axis, the ground truth for what was segmented for reporting purposes by an echocardiographer. And the relationship is fairly consistent with an R-square of 0.9. And shown here is the correct categorization for severe, moderate, mild, and normal LVEF. And so the performance is relatively good. Of course, there are some outliers, but the general performance for LVEF estimation is about 95 to 99%, depending on what range we're looking at. And we use the order of thousands in terms of the echo data available. We're fortunate to have the access to the Vancouver General Hospital imaging or echo archiving database, which includes a total of 150,000 echo studies over the course of 10 years, which we have ethics approval for access for these studies. Of course, they're not going to pull 150,000 echo studies. There's no space from the storage point of view for processing, but it does allow us to have a fairly robust data pool to do these studies with. We then apply this machine learning model for LVEF assessment to a portable Android device. And shown here is our application kind of in action. That little dot in the corner here is the application that runs in the background and is kind of functioning as a screen grabber and has this overlay here where it provides information in terms of the view as well as the image quality. And so this image quality view bar is intended to try to help scanners optimize their views if possible. It also actually allows for the acquisition of images as they come up. So I'm showing this on pre-recorded images. However, you can actually run this application in real time while you're scanning. And what would happen is, as you get to a specific view that's detected on here, it actually acquires those images for later analysis. And so if you actually have a slightly better apical 4 chamber view in 2 minutes, it'll actually record the better version. And that's just for the AI application. You can continue to record images as you normally would with the POCUS device. It'll be in a slightly different area. So the area where, say, these images get acquired to are shown there. And you can later do segmentation of the images that you have. The LVEF segmentation application is for apical 2 and apical 4. I'm just showing the apical 4 here. And based on what we can see, it looks relatively correct. Although the segmentation could be potentially optimized at the end systolic frame, but you can see where the segmentation is occurring and decide for yourself whether or not it would be considered accurate to use that number. As I mentioned, the up translation or up conversion of images can help with several different tasks. In this case, we apply it for the application of segmentation. Shown in the middle here is the real image, so these are 2 different patients. So this is patient 1, patient 2. These are the real apical 4 chamber images from these samples. The image quality is not particularly poor, and we can see that it looks worse when you down translate it, and then you can up translate it as shown on the right here. And there is an improvement in terms of segmentation accuracy. And the way that's tested is basically having the AI model segment the true image and looking at the area that is obtained, then segmenting the higher translated images and looking at the area that's obtained, and then comparing that with what is actually segmented by the level 3 echocardiographer on the true images. The translated to high quality images have a closer relationship with the level 3 echocardiographer segmented samples. And so it does show that it helps the machine learning model perform this particular task with greater accuracy. Again, application of the up conversion to POCUS images. On the left here, we have an example of the POCUS image here. The segmentation, you can tell just from the look of it, is suboptimal. It doesn't catch the base because it has this loss of subendocardial or endocardial definition. When you translate it up to a higher quality, what happens is the segmentation is optimized, and it's relatively closer to what was segmented by the level 3 echocardiographer on the original POCUS images. And so this is possibly a way to help enhance the images and performance of tasks. Some work that we have in the pipeline and that's under review is estimation of LVEF from the short axis view. So in this case, the parasternal short axis view at the papillary muscle level. And the reason that this is of interest is apical 2 and 4 chamber images, although they're not particularly difficult to get, it does require 2 images, and the best images for segmentation would be those that are not foreshortened, which can sometimes be a challenge, particularly in scanners that don't quite have as much experience. Having some method to estimate LVEF from a single view is appealing, and so we looked at the papillary short muscle level for LVEF assessment. And what we can see here, and I don't have the full results posted because it's under review, is that we, when we used 2,700 patients and had biplane Simpsons measurements for each of these samples, when we trained for the short axis view, there was a high correlation in terms of LVEF estimation just from the short axis view when compared with the Simpsons biplane true LVEF measurement. And so that's exciting in the sense that it's a new potential way to assess LVEF in the context of limited images available. Another interesting study that's under review right now from our group is the conversion of view. And so I want to just make clear that this particular model is showing what could be, what a different view looks like for a particular patient. It's not meant to replace getting that view, but it's potentially to help guide getting that view. So what we did was had the model trained on apical 4-chamber images and had the output as being the expected 2-chamber image view. This particular figure shows one patient up here, the second patient down here. For patient 1, this is the real apical 4-chamber image. The machine learning model produces what is the expected apical 2-chamber view. And this is the real apical 2-chamber view here for this particular patient. The way this model was assessed was looking at the segmentation area for the left atrium as well as the left ventricle, and compared it with what the segmentation area is on the true image to ensure that they are similar. You can see the same type of thing here for the zoomed in view of the apical 4-chamber image in a different patient. This is the produced or apical, the fake apical 2-chamber image, and this is the real one shown here on the far right. It's not meant to replace getting this image, like I said. It's supposed to be shown potentially to help the scanner get to this image. And this is of relevance because some of the machine learning models that are commercially available now are using examples or textbook examples of what the ideal view is, when potentially we can provide what the expected view is for a particular patient, given the data that is input as, say, apical 4. But this potentially could be applicable to other views as well. And so moving on to detection, there's a lot of room to move with regards to this particular space, because now there's many different disease states that could be investigated. But one of the landmark papers in this area would be considered this one by Zhang et al. In 2018 by Raul Diel's group. I think he was still in California at this time, but he is now in Harvard or Boston. And so this particular paper, as I've kind of alluded to before, is detecting disease states with regards to echo images. But as I'd mentioned, obviously they have a model for view classification here. They have a model for LVEF as well, and with the results shown over here. But they were looking at the detection of hypertrophic cardiomyopathy, amyloid, and pulmonary arterial hypertension in an enriched population. So I think these came from actually cardiomyopathy clinic in terms of where this data came from. But it does show that the AI model could predict hypertrophic cardiomyopathy with an area under the receiving operating curve of 0.93 for HCM, 0.87 for amyloid, and 0.85 for pulmonary arterial hypertension. And so these were one of the early studies for detection of disease states. And there have been some other studies that have looked at ECG as well in terms of predicting disease states when compared with echo, but this is one of particular interest. Another study that has just came out about a week or two ago from Circulation is this model that came out of Taiwan for detection of regional wall motion abnormality. There were 2 papers, I guess, for detection of regional wall motion abnormality this year. One of them had a smaller sample size. I think they had 120 patients, whereas this one has 6,454, and so a significantly larger sample set. And this study trained and tested on these 4 views. So parasternal long axis, short axis, apical 4 and apical 2-chamber for the detection of regional wall motion abnormality as labeled by echocardiographer in terms of what the ground truth was. And so what you can see here is that in this study, the investigators looked at both segmented and non-segmented performance. They actually did segment, or had some person actually identify a region of interest for where the walls were and identified it respectively as shown here to try to assist the model. 6,400 patients is quite a bit, but from the point of view of the machine learning model, it might not be quite as much as would be considered ideal for training and testing for regional almost abnormality if no segmentations occurred. This is the performance of the model. The overall external sample, say for testing, in terms of sensitivity, was about 82% overall, so pretty good, and specificity about of 82% as well. There was a slight difference in terms of the prevalence of regional wall motion abnormalities between the testing and training set as well compared to the external, but still enough. As you can see, what typically happens is when you have the validation results are a little bit different with the training testing results compared to the training validation set compared to the testing set. It usually is a little bit of degradation because it's an entirely new set of data. And in this case, it was actually a data set that came from a different institution. This is the results overall. The model that they used with segmentation and overall results with good quality images only had an area under the receiver operating curve of 0.89 with the performance statistics that's shown on the previous slide. However, when you take away segmentation, as I had mentioned, the performance drops significantly. And so they probably would have been able to obtain a good performance if there were enough data sets, even without segmentation. But because 6,500 echo images or echo videos is not considered a very, very large number from an AI point of view, you do need the segmentation in order to help the model along. When you go down to including medium or low quality images, the performance drops further. And so much like a human would have difficulty identifying regionals, if you're looking at low quality images, you see something similar with regards to the machine learning model. These are some of the studies that are of interest, and I didn't necessarily go over all of them, but there are different ones within view classification, segmentation, measurement, and picking up abnormalities. There are other studies that looked at strain in terms of picking up restrictive cardiomyopathy and HCM, which were some of the early studies from Sengupta's group. But I did focus on basically the ones that use 2D echo images because they're the ones that were probably considered a little bit more complex. So what's next? It's I think it's fair to say that echo and AI research are probably going to be implemented from the point of view of general workflow for the echo lab at some point. They're going to be integrated into our imaging processing software, as well as maybe potentially the high-end ultrasound or high-end echo machines. However, I think my group is particularly interested in POCUS, and I think it's because there's been this explosion in terms of the number of POCUS devices available and the ubiquitousness of this particular imaging modality. And the reason for that is, I think these devices have become quite small, they're portable, they're no longer significantly expensive. So they used to be, $10,000 plus. Now you're getting down as low as $3,000 to $4,000, depending on which device you're looking at. And so this type of imaging is going to be available widespread. It's going to be a part of medical school training and general residency training. And so it is going to be something that's used more frequently. And with the use of, say, cardiac ultrasound by novice users, there is probably going to be a little bit of a need for some guidance or some mechanism that will allow for augmented interpretation or safeguards to allow for automated alerts for major pathology. And so the ultrasound manufacturers also know that this is the case. And so there have been a couple that have gone on the market in terms of offering AI-powered assessments of various things like segmentation and LVEF. Shown here is the LVivo application from the GE Vscan. What you can do here is you acquire different images, including, say, this apical 4-chamber image, you record it, then you turn on this application and apply it to a collected image, and it will segment it and provide you with an estimate of the LV volume and as well as LVEF. In their rush to get out, they did have to recall it once earlier because there was a little bit of overestimation of LVEF, and so it's back out now. So I think they fixed that issue, but it sometimes is a little bit out earlier than expected. Not to be outdone, Butterfly also had an LVEF application that was available for a short period of time, and in this case, it was only out for a very short period of time. And so I managed to log on quick enough to get a screenshot of what the interface looked like. And unfortunately, it was applied to a blank screen because I didn't have an echo image to apply it to. But they gave an inaccurate LVEF in this case, but did unfortunately have to recall this particular model. And it hasn't been re-released in the US at this point. It is available now in the UK and Australia, as well as New Zealand. And so there's obviously interest in this area in terms of getting these models out, but it does require some oversight in terms of what's considered accurate enough for clinical use. This model that's commercially available is interesting. It's not necessarily focused on LVEF, although this company does offer that particular module with their product. This one actually looks at how to obtain an ideal image. So shown here is kind of the textbook view of what a scanner is trying to obtain. And this product will instruct the scanner on how to get to that particular view based on AI-based algorithms that were developed. And so I don't necessarily know the performance of this particular model. I think they tested it on nurse practitioners or allied health and stated there was a significant amount of, or significant number of success with regards to obtaining required views using this particular model. On the left here is actually a bar for image quality, and so this is not a video, but this would go up if the closer you get to this particular ideal view here. And so this is a sign that AI models are going to be everywhere soon. There was actually a formal collaboration announced between the American College of Cardiology and Butterfly IQ for what was alluded to be a heart failure study, which with a device that might actually be used in the home. They didn't give any particular details, but the fact that there is formal college collaboration with this ultrasound manufacturer now demonstrates that this is kind of the direction that many of the products will be going in. Is there's a move towards getting clinical data, which I think is what everyone is waiting for in order to start using these models the way that industry thinks that it should be used. And so what are we doing in BC still? So we are working with partners, like a local partner here with regards to an ultrasound manufacturer, but we are working to build models that are applicable for every kind of vendor, and so not specific to any specific manufacturer. We're part of the Supercluster research program, which is looking at POCUS with application of our AI models for distribution in particularly rural settings across British Columbia, with the intent of having it augment image interpretation and assist in clinical care. So right now, there are supposed to be about 80 devices that have been sent across British Columbia. And in concert with this infrastructure, there was a CIHR grant that was awarded to Teresa Sang from our research group, looking at COVID-19. And so the point for that is supposed to be potentially the application of these AI models, in addition to building new AI models that include things like lung ultrasound for the diagnosis and prognosis of COVID-19. So these are all underway at the moment. So lots of exciting things happening with regards to AI and cardiac ultrasound. I think the integration into our general workflow as well as to focus devices is going to be inevitable. And the machine learning models are pretty robust, but it does require high quality data. And I think the need for, say, accurate annotation is actually very important, or deciding what to use as your ground truth for these models is very important. And so there is some thought that's required in order to build these models so that they're clinically useful. However, once they're up and running, I think there's a tremendous benefit, which the potential for improving image quality through either the feedback mechanism with view quality assessment, as well as the up conversion or up translations that I showed previously. It'll improve accuracy of diagnosis, decrease variability in terms of measurements and segmentation, potentially improve access in patients that are in resource limited settings, hopefully reduce costs. And so this would be in the setting of potentially being able to avert unnecessary studies and optimize patient care. And so with that in mind, I'd like to thank my team, which is a partnership between computer science and biomedical engineering, as well as clinical cardiology, and as well as my mentors, Teresa Sang and Parang Abimusini. Thank you for your attention. I'm happy to answer any questions at this time. And I see that there are some questions in the...
Yeah, so yes, just like to thank so much in terms of Christina's wonderful state-of-art review in this very dynamic area. And so this is obviously will have significant impact in our clinical practice down the road. And Christina's focus, I think, on POCUS is actually important and strategic, in terms of really actually bringing echo widely to the application. Just a couple reminders. One is that you can ask your questions live as well, if you actually go into participant and raise your hand. But we do actually have a number of questions. Maybe I can start out by, now Rob Inlands did actually have a couple questions which were similar to the questions I had as well. Yeah. And that is that it was fascinating to see that you can actually up translate, the images, and yeah. From a not such great looking image, to something that looks, even to somebody, who's a not an expert, wow, I can be as good as my colleagues. And so the question is, when you do that and when you actually do the analysis, we were always taught that the data source, the source data is always the most valuable, that anything you process will actually lose kind of the data content, but it appears not to. So this is really fascinating.
So I mean, I think yes. So I think when we actually have the images displayed on the computer screen, they're already down, like degraded compared to what is obtained on the machine itself, and we just can't perceive it. It looks the same to us, but it's not the same from the point of view of, say, like strain analysis and other, like, say, computer related algorithms. I have to say that I mean the up conversion, of course, like everyone's a little concerned that these are fake images now. But from the point of view of when, say, an echocardiographer actually, say, traces a suboptimal view, like, I mean, we do use things like motion and like play the images in terms of trying to determine where the endocardial border is. And so the way that I guess we determined whether or not it was considered accurate is comparing what the segmentation looks like on the upconverted versus the normal, and what the level 3 echocardiographer traced. And so I think, yes, there is obviously some signal there that allows for the up conversion that we can't really see. I mean, like, there's little speckles on the side where you can't see the endocardium, but obviously from a machine learning point of view, they kind of recognize what the images look like side by side in terms of this is what a POCUS images look like, and this is the paired like full functionality platform looks like, and that little speck over there actually is the border. And so I mean, it's not 100% accurate by any means, but I think it does seem to help with performance of these kind of tasks.
Yeah, so that's fantastic, and but it really actually illustrate the power of machine learning being able to take data that the eye.
We can't even see. Yeah.
Absolutely. Yeah, fantastic. And so a couple questions, and Rob had one question, and Taish Coutinho also had a similar question. That is that, in terms of the workflow, which, you already illustrate, I think a lot of part about already, and that is what do you think, in the very short term, we're going to actually see that's going to be incorporated into our workflow, and what do you think, if you visualize 5 years down the road, maybe we don't need echographers anymore.
No, I mean, I kind of think that I don't know how far we are exactly out from this, but when you read an ECG now, you have a preliminary read there, and you change it to what you think is. I mean, sometimes it's completely wrong, and you're like I don't know what it's looking at, right? But I do kind of think that there will be models that, like, some of it has to do with the need, right? Industry is not going to implement into their products unless someone's going to pay more for it, right? Like they wouldn't go through the trouble. But I think there probably is going to be an ask at some point to automate things like measurement or identification of end-systolic and diastolic frames and segmentation, so that the sonographers don't have to do it, or you don't have to redo it, and then you might be able to increase your work, like your capacity in the lab, because you're not having to process, right? So I think that that's kind of the earliest thing, is because you still have a level 3 echocardiographer that has to look at all the numbers. And so even if it's wrong, so I think from the point of view of, say, liability and whatnot, even if it's wrong, you can fix it, right? And so I think that might be the earliest implementation, is actually in regular echo lab workflow, just integrated into, say, your processing software or your reporting software. And I think some of the companies are starting to do that a little bit already with things like segmentation. But yeah, having an automated, end systolic, end diastolic, and wall thickness, as well as regional wall motion abnormality kind of analysis is appealing from the point of view of reducing your reporting time and processing time. So I think that's kind of the low hanging fruit, I think, for this kind of technology to get implemented.
Yeah. Well, even for a heart failure doc like me, I would love that, because
yeah, right?
getting measurements, diastolic function, oh my God, we love it, but it's a nightmare, and we understand.
I mean, yeah, it's good to have like I think it basically gives you an idea. It might be wrong, but you can still decide then yourself whether or not.
Absolutely, yeah. And so there were also a couple questions on kind of a specialized settings, but also in terms of, the broad impact. So the question is, for example, in the setting of patients, like a COVID patient, who are in the ICU or have, sort of a concomitant comorbidities in that type of setting, do you think that could still be able to develop, AI type of tools for those type of specialized setting? And maybe we can talk about the general one momentarily.
Yeah, I mean, I think it's possible, but it might be a little more challenging, right? Because I think what you're trying to do, you potentially could use things like the upconversion of image quality to try to enhance those images. If you're trying to perform, like, say, make models specifically for that cohort, you need to determine what your ground truth is. So if you're trying to determine LVEF or segmentation, what's your gold standard, right? Like, so if the image quality is very poor, your gold standard already is compromised. And so I think that's kind of the challenge of trying to apply AI models to very, very suboptimal data. Is it's possible, and and to be honest, when we've done these studies looking at just poor quality images, it's better than a person in some ways in terms of consistency, like, because I mean, like, in terms of getting repeated measurements and whatnot. But it's still not great, because you had to have some kind of gold standard, right? So I had to interpret a suboptimal echo image. I think the EF is between 45 and 60%, right? And so the model can only be as good as what I gave it, unless you're using something like MRI or you would have to almost use like a more advanced or alternate form of, say, method for assessment. So MRI EF is this, right? And so in that case, the AI model probably would outperform the echocardiographer reading it, right? Because it's training on like a very specific number then. So those kind of research I think is possible, but I think you just have to be thoughtful about what you're considering your gold standard or reference standard, because if there's a very high amount of uncertainty, your model is going to underperform too. It might not be useful then. But yes, I think it's important, but it does require a little bit of thought in terms of how to go about doing it.
Yeah, so the complementary question is actually the other side of the application, in terms of really broad community. And, we were talking about earlier in terms of applying these technologies, to patients who otherwise may not have access, rural areas, and we, for example, look after patients in Nunavut, and then the
Great,
question,
right.
can we actually do this, even with their cell phone and things like that? Do you actually, this is a kind of the ultimate democratization, or, sort of addressing the inequality in access, in terms of technology. Do you visualize, in fact, 5-10 years down the road, and obviously this is very much aligned with your interest, as a unique opportunity?
Oh, yes, yes. So I think this is where kind of, so this is an opportunity for POCUS in general. So even if you take the AI piece of it out, POCUS has been helpful and is helpful for those kind of communities in general. And so just because it allows for imaging to occur, and there are interfaces now and companies that actually provide what's called like tele-imaging assistance. I can't quite remember what the term is, but basically, if you don't know what you're doing, you can call them, obviously for a fee, and they will help you scan. And so I think that in and of itself is already an improvement. But of course, like having an AI model integrated in there takes away that step where you can potentially get an answer without having to call a friend or call a company to give you some advice with regards to that. But I think it's because of POCUS that this is even on the table as being a possibility. But yes, I think application of these AI models to places where you don't have ready access to a level 3 echocardiographer or level 2 echocardiographer or radiologist in the middle of the night is very useful, because at least you would then get broad strokes, very abnormal LVEF, very abnormal regional wall motion abnormal, and maybe you should send them out rather than waiting until like 3 days from now to get the ultrasound, right? So I think it's, I think it is a tremendous opportunity from that point of view. And we are looking at that, I guess, with the supercluster project, but it is something I think that needs to be fleshed out a little bit more in terms of utility.
Maybe just, I know the time is running short, maybe just a couple more interesting questions. I know it's a long list of questions popping up. So one is actually, we talk about whether we still need echographers or not, but what do you think, the future of echo training is going to be like, and we now worry that, a lot of...
like that you don't know how to do the measurements anymore?
yeah, exactly. It was, cardiology trainees, in terms of bedside skills are deteriorating because they have...
I mean...
is this, maybe echo training takes only, a couple of weeks because, so what do you...
I mean, I think that you still need to, at this, I mean, it's so new now, right? I mean, like 20 years from now, yes, when this stuff works consistently and in the same way that, say, like ECG works for giving you intervals, like maybe you don't need to sit there and like try to calculate everything. But I think that it's very important that you still know how to do all these measurements manually, of course, and even in the foreseeable future, you need to be able to do them manually because technology can always fail, right? And so you really don't want to be in a situation that you have no idea how to scan or no idea how to measure things, because maybe it will shorten echo training in some ways, but I think that basically part of training will basically be troubleshooting, if that's really part of the integrate. So once it's starting to get integrated into clinical processes, you'll have to learn how to troubleshoot it and how to fix problems and also do it manually. I think that's still important. And I think radiology has had experience with that already. And so they still need to do, I think, manual measurements if required.
Yeah. And maybe the last question, so this is really fascinating. Last question is, can you, or do you visualize, eventually have the clinical information, sort of other components of our data set, integrated with the echo interpretation, so that you can really have a kind of a smart report,
like a prediction kind of report. So I think, like I said, the majority of research kind of, like for the most part for AI echo research, has been on this view classification, image quality, and measurement piece, because it's taken so long to even get that point. Like, so now that we're actually over that cliff, now you can actually come up with really interesting questions. I think it's very exciting now, because now you can actually talk about pathology. And so you're wanting to integrate all the information you have available, and maybe not in an overly burdened way, but this will potentially be, if you're trying to predict outcome of somebody with, certain disease state, you're going to put there's no reason you wouldn't put their age and their sex and their like whatever other information in, and you potentially even predict the development of disease, you predict outcomes, you predict prognosis. And so you would definitely start to integrate other features into your ML model. But yes, the focus has been on just on imaging right now. But if you step back as a clinician, yes, you're going to use all the information you have available. If you're trying to say, will this person with a slightly thick LV and MGUS develop amyloid in the future, like in 10 years, like what's the probability of that? That's kind of the questions that you can now actually start to come up with, which I think is the exciting part. Right?
Wow, so that's fantastic. And I'm reminded that recently I was chatting with Dr. Braunwald, who said, who was absolutely convinced, right? That after, the clinical skills, after the stethoscope, the next impact in cardiology is the focus with AI, and that's directly in Christina's hands. So we need to, so.
I can't talk to Braunwald.
Yes, so fantastic. And just on behalf of the whole Ottawa community here, thank you for a wonderful presentation. I should mention also Dr. Thibault was in the audience.
Oh yes, anyway, I'm lucky. He said he was on service actually, so I'm glad he.
Yeah, and so thanks so much for a wonderful presentation. Enjoyed very much, chatting with you, and hope you enjoy the rest of the day, as much in terms of chatting with the other folks in Ottawa. And so that concludes this session. Next week, actually, I'll be doing the presentation. And then also, there's an American Heart Association that's actually going on as well. So thank you so much for joining us again. And also thanks, Christina, for a wonderful presentation. Take care.
Thank you.